Good afternoon and good morning to those not on the East Coast. My name is Heidi Leftwich from the University of Massachusetts and the SMFM Education Committee, and I will be moderating today's webinar as well as the Q&A session following the webinar. I'd like to first welcome everyone to today's webinar, COVID-19 and ICU, Respiratory Failure in Pregnancy, given by Dr. Cornelia Graves. Before we begin, I'd like to take a moment to share a few housekeeping points for today's webinar. We are using computer audio for today's lecture. Everyone is muted during the webinar except for the speaker. We are planning to hold all questions to the end for the panel Q&A. This webinar is being recorded and will be available on demand from the SMFM website by tomorrow at 5 p.m. Eastern Standard Time. Following the webinar, again, there's going to be allowed a 30-minute Q&A segment. You may answer your questions into the chat box to the right of your screen or submit questions anonymously during the Q&A feature at the bottom of your screen. The panelists are going to try to answer some site-specific questions offline to keep as many questions that pertain to the entire group to be prioritized. We promise to get to as many questions as possible. With that, I'd like to welcome our guest, Dr. Cornelia Graves, the Medical Director of Tennessee Maternal-Fetal Medicine and Professor of the University of Tennessee, and our Critical Care Specialist for our panel, Drs. Dina Goffman, Associate Professor at Columbia, Dr. Tori Halscott, Assistant Professor at Johns Hopkins, and Dr. Michael Dombrowski, Assistant Professor at Washington University, to today's webinar. Thank you to each of our panelists for their time, and with that, I'm going to start you off with Dr. Cornelia Graves. Thank you.
Good morning, everyone. I'm really pleased to be able to give this lecture speaking about respiratory failure in pregnancy. This lecture comes in two parts, and I'm hoping in our time period to be able to get not only to the lecture, but to the case presentation. So we'll go ahead and get started. Of course, I have no financial disclosures. I think one of the most important things that we're going to discuss today are the physiologic changes of pregnancy. And I'm going to try to point out those things that you may want to talk to your intensivist about if your ICU is one of those ICUs that is closed, or you may not have a maternal-fetal medicine specialist readily available. And then we're going to talk about how we can treat respiratory failure. Respiratory insufficiency is really the most common reason for patients who are pregnant to be admitted to the critical care unit. It accounts for about 1 in 4 patients who are admitted to the critical care unit. Interestingly, in our institution, for example, people who have arterial lines or need drips often don't go to our ICU. They stay in our labor and delivery, but if they need ventilatory support, then they will go to the ICU. This may falsely skew our numbers of the number of critical care patients that we actually see. And it complicates about 0.1 to 0.2% of all pregnancies. I think one of the most important things in pregnancy are the physiologic changes. Hyperventilation begins in the first trimester and increases by about 48% at term. This is actually stimulated by progesterone. Progesterone also increases your minute volume about 20 to 40% above baseline. This is very important because in pregnant women, tidal volume is actually increased, which is something people may not understand simply because of this increase in minute volume. Most people think that pregnant women have a decrease in tidal volume because the baby is pushing up, but we'll talk about why that is not the case. Oxygen consumption is increased by about 20%, but if you look at pulmonary dynamics, your FEV1 is unchanged. As I said, your tidal volume is increased due to your increased minute volume and your increase in the anterior and posterior diameter of the chest in pregnancy. What is decreased in pregnancy is your functional residual capacity. It's decreased by about 18%. This is one of the most important features of pregnancy because in pregnant women, respiratory failure occurs much more quickly than in non-pregnant patients due to this decrease in functional residual capacity. So for example, in most ICUs, a respiratory rate of 30 to 40 may be well tolerated. In pregnant women, a respiratory rate of greater than 24 is considered to be on the edge or possibly indicate the need for greater respiratory support. Pulmonary vascular resistance decreases by about 34%. And then another thing that predisposes the lungs to fluid infiltration is this decrease in call-out osmotic pressure, which changes about 14% in pregnancy, except in patients with preeclampsia in the postpartum period where call-out osmotic pressure can decrease up to 35 to 50%. So in pregnancy, what we really have is a compensated respiratory acidosis in which your pH remains unchanged. Your resting arterial CO2 tension, however, is decreased to about 30 millimeters or less. This is really important because what happens is that when you get a blood gas and a pregnant woman's CO2 is 40, she probably is retaining CO2 and is not normal as it would be in someone who is non-pregnant. There's also a increase, or your resting O2 tension is about 105 because of hyperventilation. And this shifts your oxygen dissociation curve to the right, which serves to help the fetus offload oxygen from the mother. If you look at these graphics, one of the things I want to show you is your minute ventilation progressively increases as pregnancy increases, all the way to term. Oxygen uptake also increases. Almost all the way to term. About 8 months, it begins to decrease slightly, and your basal metabolism also increases during this time. This is a graphic of the things that we have been talking about. You will see that your respiratory rate here is your respiratory capacity is here. It's basically unchanged. Your tidal volume, however, is increased. Your residual volume is decreased and your functional residual capacity decreases. And as you will see throughout pregnancy, this functional residual capacity decreases significantly. Excuse me, let me go back if I can. Decreases significantly so that pregnant women in the 3rd trimester are most likely to get into respiratory trouble. Again, this is a graphic of your fetal hemoglobin. This is the dissociation curve. And what I want you to see is that the fetus, even when the mother is saturating 60 or so here, mother is saturating 60 or so here, the fetus is still able to offload oxygen fairly effectively. So this is, while people worry about the fetus and oxygenation, it is really important to know that the fetus actually compensates very well. Now, what is interesting is hypoxia actually increases uterine activity, which is something that we really need to be mindful of when caring for patients with respiratory distress. Well, there's several causes of respiratory distress. There can either be pulmonary or extrapulmonary. Today, we're going to focus on viral pneumonias, but there are also asthma exacerbations, pulmonary infections, pulmonary edema, systemic inflammatory response, which will be our case, pulmonary embolism, and air embolism. Then there are non-pulmonary things that we have to think about, such as drugs, myocardial infarction, aortic dissections, acute chest syndrome, and amniotic fluid embolism. It is important to remember that anxiety is a diagnosis of exclusion, and it should only be diagnosed in a patient once you have excluded all other causes of respiratory compromise in patients. Well, let's talk about respiratory failure. Respiratory failure is due to, as we talked about, inadequate gas exchange due to pulmonary and extrapulmonary conditions. Most people, when we talk about respiratory failure, talk about hypoxemic respiratory failure, i.e. the patient is not getting enough oxygen into the lung. However, for the most part, the patient is able to exchange CO2. However, in patients, you can also have type 2 failure, especially in patients with asthma, in which the patient cannot adequately exchange CO2 and is retaining CO2. So when you're looking at your dynamics for respiratory failure, a pulse ox is great, but it does not tell the whole story. So therefore, if you're concerned about a patient, an arterial blood gas gives you the full picture and helps you to determine which type of failure the patient may have. As we talk about the mechanics of breathing, As you know, breathing, you inhale in, there's oxygen going into the lungs. The diaphragm is very important in how the lungs can expand. And then so the space inside the chest actually increases. As we exhale, the space inside the chest decreases. This is going to be really important when we talk about ventilator management, because how we give breaths on the ventilator should really mimic how we breathe normally. Most of us take a short in breath, but it takes us a little bit longer to excrete CO2. And so ventilator, when we're setting the ventilator, we need to keep that in mind. Again, if you look at the physiology of gas exchange, one of the things we're going to talk about here is pulmonary shunt. Blood comes in from the pulmonary artery. It then crosses the capillary, the alveolar membrane, and the respiratory membrane. Blood is then diffused into the red blood cells. Now, what happens if this area is injured? Then blood cannot diffuse into the red blood cell, therefore resulting in hypoxemia. So you may be able to get air into the alveoli, but the alveoli is not functioning to let oxygen across. And if this membrane is injured, such as an ARDS, you're going to have the issue on the other side as well. CO2 cannot diffuse back into to the alveoli, back into the red blood cells and be exchanged. So when you're talking about respiratory failure, especially in adult respiratory syndrome, you're going to have type 1 failure because oxygen cannot diffuse into the red blood cell, and type 2 failure because you cannot exchange your CO2. Again, this is just another way to look at shunt. Blood is passing through the pulmonary capillary, but either the alveoli are collapsed, which you can get an ARDS, or consolidated and fluid filled, which also are an ARDS. So it comes by, but there's no oxygenation of the blood and there is no CO2 exchange. So it's really important to look at shunt. And one of the ways to look at shunt is to divide your FiO2 by your PaO2. And if your a PaO2 by your FiO2, excuse me, if your PaO2 is, let's say if your FiO2 is 100 and your PaO2 is 200, then that would mean that, for example, you cannot exchange a gas adequately and you're in respiratory failure. If the result is 300, then you can exchange some gas, but you have some element of respiratory compromise. And I'll be happy to talk about that and the equation a quick equation you can use in order to evaluate patients at the bedside for the level of shunt that they have. Again, if you look at shunt normal, if your ratio, P up to P to F ratio is here, should be greater, if it's greater than 400, that means it's equivalent to PaO2 or room air of greater than 80 and you're normal. When you get to less than 400 and it's equivalent to less than 70, you're hypoxemic. Less than 300, as we talked about, acute respiratory failure. Less than 200, critical respiratory failure. So again, I think before we talk about ventilator management, it's really important to try to talk about the oxygen pathway. So the air is going to come into the ventilator. Maternal lung may be affected, as we talked about, inflammation, pneumonia, or ARDS. That's one way O2 exchange. But the other thing you have to be aware of is that O2 exchange occurs in other things. So when you're managing these patients, it's just not about managing the lung. We have to manage the cardiac output, making sure there's no aortic cable compression. We need to be worried about anemia. We need to also think about the uterus, whether or not the patient is hypotensive. What about whether or not the placenta needs more perfusion? What if we have respiratory failure in a baby with IUGR? That is something to think about. Then there's oxygen that goes into the umbilical artery and the umbilical vein. And then of course the fetal circulation, which again can be affected by things that affect the fetus. So if you have a mother who is compromised and a fetus who is compromised, outcomes for the fetus may be worse in this particular situation. So one of the things that we're going to talk about is how to determine when patients need to be sent to a higher level of care. So respiratory failure, you want to evaluate the patient, examine your patient. This includes a pulmonary exam with the stethoscope. Assess your oxygen saturation. Is it less than 95% in pregnancy? That's concerning. Assess your ventilation. Remember type 2 failure. Don't say, oh, she's setting 98%, but she says she can't breathe. I think it's okay. No, we need to obtain an arterial blood gas and make sure that the patient is exchanging CO2 adequately. And then you want to assess your respiratory rate. Is it greater than or equal to 30? And then you need to ask yourself some key clinical questions. Does your patient appear to be becoming unstable? Now, maybe in your institution, you have great help at 2 a.m. At my institution, I normally do not. So I always ask myself, what are my available resources? You want, if you have an unstable patient, respiratory patient, not to wait to 2 a.m. to say, gee, you know, she's suddenly decompensated, because these patients don't normally suddenly decompensate. The one issue in which a patient may suddenly decompensate is probably flash pulmonary edema. But when you're thinking about patients with pneumonia or those types of diseases, they do not just suddenly decompensate. Said, can your patient maintain adequate oxygenation on your current therapy? Your patient's on a face mask, she's on a non-rebreather, but she's still struggling. What is the status of your fetus? Remember, we talked about the oxygen pathway. We have to oxygenate our uterus and we have to perfuse our uterus. So if we're not able to do those things and the patient is contracting, she probably doesn't need magnesium sulfate or tocolysis. She probably needs improving of her oxygenation so that she can adequately oxygenate her fetus, which will then treat her preterm labor and possibly an abnormal fetal heart rate. The other thing to ask is, does the patient have a full stomach? If the patient has a full stomach and has recently eaten in pregnancy, which is in pregnancy, you want to think about that because a full stomach increases the risk of aspiration. Now, what is a full stomach in pregnancy? Any patient who's eaten in the last 6 hours, a full meal is considered a full stomach. So if your patient comes in, let's say she has COVID or influenza, and she comes in short of breath, and then she says, well, I've been eating, I just stopped at McDonald's on the way. She has a full stomach, and you have to consider that when you're getting ready to manage this patient. You want to consider intubation and early in the pregnant patient population for 2 reasons. One is because pregnant women, we're going to talk about, are hard to intubate. And 2, you can protect your airway, which makes it much easier for you to then manage the patient otherwise. The other thing you need to determine is whether or not you're going to do fetal intervention. There's no need to take your fetal monitor to the ICU and decide that you're going to put her on full and monitor the baby if we've already decided that you're only going to rescue the baby if the mother codes or has some other or has a morbid event. So therefore, you need to decide right off, are we intervening for the fetus? In what circumstances are we intervening for the fetus? And how will we intervene for the fetus prior to placing the monitor and doing those types of things in the ICU? And then you want to investigate and treat the underlying cause. Now, I know we're in COVID-19 era, but I will tell you that just recently in our hospital, in fact, she's still there, the patient came in, and the first thing I said is, I don't think this patient has COVID. And, and so the day I was talking to the resident, and I said, there are many causes of fever. And so it's important that we don't get so myopic in this situation that we forget other causes and we don't investigate those when the patient comes in. Now you can think about intermediate therapies, short-term support for complications that may reverse rapidly, i.e. mask oxygen or a non-rebreather. CPAP in pregnancy should be used with caution. Keep in mind that CPAP blows air into the stomach, and if you're blowing air into the stomach, the patient is more likely to aspirate. If the patient is a difficult airway and you can feel like that you need more support for intubation, then a laryngeal cuff for transient management of respiratory issues can be considered until you're able to fully intubate the patient. Or if you think, for example, the patient had flash pulmonary edema, but she's now diuresed 3 liters and she's not going to have long-term intubation, this may be a situation in which intermediate therapies are appropriate. Well, what are the indications for mechanical ventilation? Hypoxia, hypercapnia, as we talked about, the increased work of breathing. People, when they are having trouble catching their breath, begin to get tired. And one of the things that the ventilator is going to do is going to allow you to help that patient decrease her work of breathing. Severe metabolic acidosis is another reason to assist the patient in order to help them blow off some of their acid. A need for sedation. You're going to need to sedate the patient because they're combative or because their increased work of breathing makes them so anxious. Reduced myocardial or systemic oxygen demand. When you intubate a patient, what you really do is you put the patient kind of on hold. And I tell people this, that one of the beauties of mechanical intubation is that you get to control the patient's hemodynamics. And if you can control the patient's hemodynamics, you can control the amount of oxygen she consumes, so that all the oxygen that you need to go to the tissues is much better utilized than if the patient continues to struggle. And then anytime you have an altered mental status. So these are your objectives. You want to improve your pulmonary gas exchange. As we talked about, reverse your hypoxemia and hypercapnia and relieve your acute respiratory acidosis. You want to relieve your respiratory distress, as we discussed, by decreasing that work of breathing. You're going to alter your pressure volumes. We're going to talk about that. Permit lung and airway healing. I can't emphasize this more than enough. That is one of the major benefits of being able to intubate or to control someone's breathing, is that you're actually going to allow the lung to stop injuring itself and to heal itself and to avoid other complications. As we talked about, one of the things you may need to consider is when you're intubating is either consider a smaller ET tube. In patients who are obese, you may need to even consider video laryngoscopy. Pregnant women are 8 times more likely to have a failure of intubation. So you need to get someone, if possible, who's experienced in intubating pregnant women to reduce the risk that the intubation is failed or the ET tube is actually placed in the wrong area, which video laryngoscopy is really helpful to avoid. So now that we've gone over that, we're going to try to make a breath. So these are your modes of ventilation: pressure control and volume control, and hopefully not, but high frequency oscillatory ventilation. Pressure control has bilevel, synchronized intermittent mandatory ventilatory support, and airway pressure release ventilation. Pressure control ventilation is for patients who either we're trying to get off the ventilator, only need the ventilator for a small period of time, are usually awake and cooperative. Volume control, assist control, which means that you actually control the amount of breath the patient gets. Synchronized intermittent mandatory ventilatory support, the same as in pressure control ventilation. The patient is able to breathe somewhat over the vent and on their own. And then high frequency oscillatory ventilation, which is for those patients in which we cannot open up the alveoli by conventional means. So the first thing that they're going to ask is going to say, doctor, we need to know what tidal volume you need. So tidal volume is your alveolar protection. It is the amount of gas exchange delivered with each breath. Consider starting at about 6 to 8 milliliters per kilogram. And you need to use your predicted body weight, for which I have provided your equation here in this slide. That means if someone weighs 400 pounds, which I will tell you in the South, that is not uncommon for us to have patients who weigh 400 pounds. They still don't need as much tidal volume as you would think. So you need to use this predicted body weight based on their height to really help not overventilate them in this situation. Inspiratory flow rate is your patient comfort. Now, most of the time, your respiratory therapist will set this. Remember, as I talked about before, we breathe in a decelerating flow pattern. So therefore, you need to make sure that this is set appropriately. The initial setting is about 60 liters per minute, and you can titrate it to patient comfort. Failure to pay attention to this parameter may increase your sedation needs. Because if you invert your I to E ratio, that's your inspiration to expiration ratio, that may be helpful in some cases, but the patient definitely is not going to like it. So make sure that this is something that you take a look at on your ventilator, especially when your patient is combative and seems to have a lot of issues with getting enough air or and it's uncomfortable. Then there's your respiratory rate. It's a titrating, you're going to titrate your ventilation. Your PCO2 is your goal. So your respiratory rate is to help you blow off CO2. You can 15 to 18 breaths per minute. You can increase the highest as the 30 to 40 breaths. And if you have end-tidal CO2 in your ICU, I suggest you use this. This keeps you from having to get gas after blood gas, and allows you to know what your CO2 is doing and after you place the patient on and set your respiratory rate. Now, your PEEP and your FiO2 are titrating your oxygenation. You're always going to start with an FiO2 of 100% and a PEEP of 5. And then you're going to decrease your FiO2 to 30 to 40% as soon as possible. Why? As we all know, oxygen is toxic to the cells. And just like it's toxic in the NICU to the pulmonary status of neonates, it's toxic to adults as well. So we don't want to leave people on 100% FiO2. And then you're going to titrate your PEEP using the scale from the ARDS Net ARMA trial, which I have included in this slide set. And you can see if you want to do a lower PEEP or a higher PEEP. But what this allows you to do is adjust your PEEP appropriately. For example, if you're doing lower PEEP, higher FiO2, if your FiO2 is at 40%, you may increase your PEEP to 8 to get appropriate oxygenation, or 50%, 8 to get appropriate oxygenation. Whereas if you're using higher PEEP, if your FiO2 is 30%, you may want to increase your PEEP first before increasing your oxygenation to get an appropriate oxygenation for the patient. This will depend on the patient, her lung volumes, and her compliance, which we're going to talk about in just a second. Now, your peak pressures are alveolar safety. The goal is to keep them around 30 to 50 centimeters per water. Now, we need to remember the structural issues that are really unique to pregnancy. I went to the unit probably about a couple of years ago, and they said, she's doing okay, but her peak pressures, we just can't get them down. And I looked at the patient who was lying flat in the bed, and she had very large breasts. So I set the patient up, and her peak pressures came right down. Pregnant women have heavier chest due to breast engorgement. This is not something that our ICU colleagues are used to. So while you're looking at peak pressures, and if you can't figure it out, look at the patient's position and make sure the breast tissue is falling off the chest wall. This will then decrease the chance that you have falsely elevated peak pressures. So here we are. These are your strategies for mechanical ventilation. You're gonna, tidal volume should be between 5 and 6 to 8. Your inspiratory rate is gonna be about 60. Your respiratory rate, 15 to 18. Your O2 saturation goal, greater than or equal to 95%. This is one of the things the first one is your O2 saturation. Most people who are non-pregnant or who still don't have a fetus inside, we tolerate between 90 and 92%. So 95 is a little higher than most intensivists are used to. So we'll need to let them know that the baby is still there and we need to give a little bit more oxygen. The other thing is your carbon dioxide goal. Permissive hypercapnia is often used in the ICU. which means that they allow the baby, allow the mother, allow the person, the patient, to then retain CO2 in exchange for oxygenation. Remember back from our pulmonary mechanics, you have to have, in order for the alveoli to work appropriately, exchange has to occur on both sides. In the ICU, they may let that go up to 100. For pregnant women, 50 is probably okay. Anything 50 or less is okay, but we don't want to have significant hypercapnia. The data suggests fetuses exposed to hypercapnia are not going to do as well as those who only have mild hypercapnia. We also don't want to have hypocapnia, which is, again, may affect the fetus adversely. You want to start with a 5 of PEEP, and you want to keep your PEEP pressures around 30 to 35. And I place this so if you want to, you can print it out and put it in your pocket if you have to then get someone started on mechanical ventilation. So when should I consider delivering the fetus? Consider delivery after 34 weeks gestation if prolonged illness is expected. There is no data, however, to suggest that delivery improves maternal outcomes. And this is some data from 1998, and actually one of the few studies out. It was from Tomlinson, Jan Whitty. This is out of Detroit. They looked at 10 patients. They delivered them. They reduced their oxygen requirements by about 28%, of course, because oxygen requirements increase about 20 to 25% in pregnancy. But delivery did not change lung compliance. So if someone says, oh, she's 26 weeks, shouldn't we just deliver her and so we can get better oxygenation? There's no data to support that. Well, what about adjuvant therapies? Remember that betamethasone is a large steroid dose. And in this particular virus, COVID, there is a lot of thought back and forth about whether or not steroids should be used in this patient population. Right now, we have not changed our giving betamethasone for the early patient, even in patients with COVID or suspected COVID. For those of us who follow the critical care literature, we go in and out about whether or not it's useful in acute respiratory distress syndrome, and may be useful for direct injury. I think this week it's in favor, next week it may be out of favor. Just know to refer to your literature to see whether or not that's something you may consider and work with your pulmonologist. Use after 14 weeks actually may increase your mortality. 14 days, excuse me, on the ventilator may increase your mortality. So it's important to know that if you're going to use the therapy, you need to go ahead and use it early in the process. Now, sedation is not contraindicated in pregnancy. It may cause changes in fetal heart rate. It may decrease your variability and your baseline, but it does decrease maternal oxygen consumption. And remember, part of the reason that we're putting patients on the ventilator is to decrease maternal oxygen consumption. So just know that your baby is going to be flat, but as long as it's not having decels, it's going to be flat in about 120 or even 110. But as long as the baby is not having decelerations, your baby is stable. And just a function of your sedation. The one thing I do want to point out in this particular slide is we love propofol, and propofol causes vasodilatation and can reduce cardiac output. So in patients who are on large doses of propofol, we need to be really careful. The other thing is for vecuronium, we need to be remember we need to avoid renal or liver failure, and we really need to work with our intensivists to make sure that we are using the appropriate sedation tools. Lorazepam and in high doses is okay. Midazolam also should be avoided in renal disease, but it's short acting. And then let's not forget our opiates that can be of assist to us in making our patients more comfortable, such as fentanyl or hydromorphone. Again, paralytics the patient really should be sedated prior to your use. And they really don't cross the placenta in small amounts, and they have not as much effect on the fetus. Any of us who do corticentesis knows this because you have to inject your vecuronium directly into the cord versus trying to give it to the mother and having the baby be sedated. So just know that paralytics should be used, especially in your combative patient, but it only should be used after you've provided the patient with appropriate sedation. What about other agents? Activated protein C may reduce mortality or morbidity in patients with sepsis. Nitric oxide can be useful in patients with pulmonary hypertension. And currently, surfactant in adults has not been well supported, and the initial trials have really been disappointing. I know that there are new clinical trials underway, but there's no data for surfactant use in adults. I like this slide. It says, so this is so wrong. A hospital needs that mask for all of us who are protecting our PPE. Now let's talk about the principles of ECMO. The basic principle of ECMO is that in patients who you cannot maintain adequate oxygen saturation, you can then remove that blood, oxygenate it outside, and return it back in. So basically that's what ECMO does. Desaturated blood is drained via the venous CO2 and drained via a venous route, and CO2 is removed. You then add oxygen back through your oxygenator, and you need to be careful to wash your oxygenator because it can be clogged, and you may not be adding oxygen back as well. So that needs to be checked by your ECMO team, hopefully on a regular basis. And then the blood is returned to the systemic circulation via another vein, such as your, so that's why you get the two VV ECMO or AV ECMO. Now, these are the ECMO outcomes in 18 patients, 4 who were pregnant. The median was 32 years of age. Median gestation was 32 weeks. The outcome was about 90%, 16 out of 18. Fetal survival was 77%, 100% of viable if the fetus was viable, and 4 patients were delivered on ECMO. So I think this tells us if we need to put our patients on ECMO, we can be successful in taking care of them and the fetus as well. Well, what about viral pneumonia in pregnancy? There are increased mortality rates when compared to the general population in some viruses. In 2009 H1N1, there was a 32% admission rate for pregnancy. Pregnant women were 4 times more likely to be admitted, and there were 6 maternal deaths. SARS maternal death rate was 25% in some countries. So it is important to understand that, yes, we're talking about COVID, but the influenza that can be deadly for pregnant women and can cause issues. And so we need to take precautions around our patients all the time. If you look at COVID, there's a couple of articles. This is Lancet 2020. There were 9 patients delivered by cesarean section. This is out of Wuhan. No placental transmission, no maternal deaths, and no increase in respiratory complications. They really thought that they delivered by cesarean section to reduce the risk of transmission through the vaginal route. And then in the Archives of Pathology in 2020, Swartz and all 38 cases, no placental passage, and there was no increase in respiratory symptoms. And currently the data suggest that in COVID, the respiratory symptoms in pregnancy are not any worse than in the non-pregnant population, which is very good. So our treatment is supportive care. Antivirals that have been used for influenza are not recommended. Currently, corticosteroids are not recommended, and other therapies. Remdesivir has been used successfully in the United States. This was used for Ebola. I know that everyone's running out and drinking chloroquine, which has caused some deaths on another end, but there has been no randomized trial. And then the HIV drug, lopinavir and Renavir, which I better know as Kaletra, has been used in some case reports. There's also a trial of hydrochloroquine and azithromycin out of France. I believe they're starting that trial in New York now, looking at outcomes in those patients. You know, I'm kind of a geek, so I think this is really interesting. If you look at hydrochloroquine, this is why some people are all excited, but keep in mind that this is in vivo and not in vitro. If you look at the untreated virus, you can see here, you can see it's still multiplying versus, or still about the same size versus the treated virus here. and you can see the virus begins to break up here with more here with more debris in this area. And if you look at this treatment here, you can see the virus actually breaks in two. This is why people are all excited about hydrochloroquine, but at this point, I don't think we have any data to suggest that we should be using it in our pregnant patients as a prophylaxis or a treatment if we're not doing it under protocol. Now, I think I'm going to try to get in my case study. So in conclusion, this is respiratory failure complicates in about 1 in 500 pregnancies. The physiology is so important, and then of course identifying that underlying cause. I'm hoping I can change my slides over. Let's see if it'll work. Okay, here's the case presentation. So this is a 32-year-old gravid woman who presents with recurrent fevers to 102. The patient reports that she's had a mild cough and a headache for the last few days. What is your differential diagnosis? Right now, everyone's differential diagnosis is COVID until proven otherwise. But we also need to remember this could be influenza. This could be pneumonia of community acquired. This really may not be pneumonia at all. This may be a pyelonephritis, or in our patient that we currently have on our antepartum floor, it may be some type of autoimmune disease. So keep in mind that we need to still develop our differential diagnoses. These are our vitals. Our temp is 101 in the 0.4 when she gets to the hospital. Her respiratory rate is 30. Note the respiratory rate, 30. Her pulse is 115. She's setting 98%, so she's still able to maintain her saturations. This is her white count. She's about 16,000 with about 5% bands. And look at her hematocrit. She is anemic at 27.2, something that we need to keep in mind in respiratory failure. This is her fetal heart rate tracing. The baby is reactive and looks like it's doing quite well. So at this point, I think that most of us would vote for supportive care. These are our labs. The COVID is not back yet, but the patient also is positive for rhinovirus and influenza A. And I particularly made it to remind people that you can have, when you get these viruses, you can have more than one. You just don't have to have one virus. So it's important to do your whole respiratory panel. So at this point, the therapies I hope you would like to initiate are oxygen, or at least observation. You don't want, this is not a patient you want to send out to the hospital. She was setting 98%, so you may not want to initiate oxygen at this time, but you do want to initiate observation, and you do want to place this patient on isolation. What about antiretrovirals? Probably not. And if you think this patient has COVID, if you think she has the flu, then yes, you want to go ahead and initiate your antiretrovirals of choice for the flu. I don't have COVID, it's allergies. It's south in the spring. The patient's temperature is 102. Again, she does not feel well after Tylenol. She states that she feels like she has shortness of breath. Now, what information would you like to know? I would think that you would want, what you like now, you want to know how, what her breath sound like, if she's had a chest x-ray, exactly how well the patients are doing, and what the fetus, and how the fetus is tolerating this as well. Her sats are now down to 88, so respiratory rate's up to 38, and her pulse is 131. And this is her fetal heart rate tracing. Remember, the fetus reflects the mother's health status. Despite therapy, the patient continues to worsen. So now your diagnosis, you have to be worried about ARDS. And I want to just talk about ARDS really quickly. It's an acute onset, bilateral infiltrates, no evidence of intravascular volume load. As we talked about before, acute lung injury, PA to FiO2 rate of less than or equal to 300. And ARDS is a PA FiO2 of less than or equal to 200. Again, these are our causes of ARDS. Today, we're going to assume that this patient has viral pneumonia. The one thing I want people to understand about ARDS is ARDS, the pathogenesis is you have endothelial and epithelial injury, cytokine injury, neutrophil-dependent lung injury, and ventilator-induced injury. And the way I like to describe our ARDS is like, I like to do things like go to the gym, and on occasion, I will cut my leg. And so when you cut your leg, you begin to bleed. And once you begin to bleed, the blood, all of your white cells and things rush in. This is the same thing that happens to your lungs in ARDS. Your white cells rush in, you get inflammation in the area. And once I get the bleeding to stop on that cut, I get this exudative type material that kind of is going to make a scab, because now your body recognizes that something has been injured. The same thing in ARDS. In the chronic phase, my scab is going to be there. And although I love to work out at the gym, my leg is just not going to bend as well as it should. And so therefore, I'm not going to have the same compliance in that skin area as I would if I hadn't cut my leg. The same with ARDS. You're going to get this chronic phase, decreased compliance, pulmonary hypertension. The issue is that most of us who do obstetrics want the patient to get better immediately. This is a long-term process, and it's going to take about 14 days with gradual improvement, and your chest X-ray may lag behind. The one thing that's going to improve before anything else is your compliance. So once you get your patient set on the ventilator, just let her stay, and then she'll let you know when it's time to start weaning the ventilator instead of trying to wean her off in 1 to 2 days. And this is a graphic that I just want everybody, this is the graphic we have already talked about. This side is the inactivation of your surfactant, the macrophages, and kind of the destroying of that area that allows gas exchange. And then we talked, this patient we intubated this patient. She was placed on IMV. We calculated her tidal volume. Her rate is 15. This is her blood gas. So the adjustment that we want to make in this case would be with her rate and because we are blowing off too much CO2. So we reduce her rate to make sure that that's the case. And her peak pressures are initially 40. Remember the positioning we talked about and those things that will help us manage this patient more effectively. This is our fetal heart rate tracing in the ICU. Day 4, the patient is febrile. She looks great. Her FiO2 is 40. She's getting better. You just need to keep her on the same clinical course. Patient was extubated, and I should say this patient in this case was extubated on day 10, and she was placed on face mask and discharged home undelivered. So I hope that in this case I've stimulated some conversation and some thought about how to take care of these patients. And I think my time is up. And so I'm going to stop now and allow others to, me to hear your questions, and I'm happy to answer those. Thank you so much for your attention, and thank you for tuning in to listen to this webinar.
Thank you again, Dr. Graves. I am going to jump into these questions. First, there's been kind of a back and forth chat with our panelists. Most of those have come forward to the entire group, but some have not, and so we'll hop back there as well. But let me start with some of the questions that are specific for Dr. Graves, and please feel free, any panelists, to jump in as well. We'll start with, would there be a role for VV ECMO for pregnant patients for refractory respiratory failure? And if so, what are the criteria and contraindications for putting a pregnant patient on it?
Unless the patient, first is the criteria would be the same as for the non-pregnant patient. When we can no longer appropriately oxygenate the patient, and we feel as if at this point in time that the patient, for example, we can only get her oxygen PaO2 up to 40 or 50, we need to start considering VV ECMO. If the patient, like I said, is 34 weeks, I think everybody would, might consider delivering, or there might be a consideration for delivery. But if the patient is 26 weeks, then I think we have to think about the morbidity and the long-term issues for the baby. So in my mind, the patient should meet the same criteria for VV ECMO, and the contraindications would be the same as in the non-pregnant patient.
Okay, and then there's a question, can you please clarify the increase in mortality with steroids after 14 days? Is this 14 days after illness starts, 14 days on a ventilator? Would this be an issue outside of an illness that begins prior to viability, i.e. someone who's sick at 21 weeks, too early for steroids, could be ill after viability? Thank you.
I think from the critical care literature, we're talking about the use of corticosteroids in that particular patient population for the improvement of ARDS. So if you put a patient on the ventilator and you think, well, gee, would steroids help? The literature suggests that if you're going to use them, you need to use them early in the course, and that after using them after 14 days may actually decrease the likelihood or decrease outcomes. And I'm not sure if that's because maybe of where the patient is and the outcomes were not going to be as good anyway, but that's a randomized control stop trial. And that's for all patients with ARDS. At this point, I would not change my treatment of someone who was 22 weeks, but now is 24 weeks and needs steroids, because the reason that we're administering them has nothing to do with trying to improve the respiratory course.
Great, thank you. And then I think most of the rest of these are kind of for everybody. So if the panelists can start to unmute them as well, and you guys can kind of coordinate and all answer, or a couple answer each of these questions, because some of them might be a little bit different depending on where you come from and what you're doing in your institutions. How often are you assessing ABGs as clinically indicated?
Yeah, I think totally agree with that, it's important to measure a blood gas, and then anytime you think that you either want to assess a change in patient status or a response to treatment, you can remeasure another blood gas then. So that's something I generally do serially to monitor a patient. There is some institution dependence to that as well. Some places are much more aggressive in monitoring serial ABGs, and other institutions monitor it less frequently. My general practice is to monitor them relatively frequently, especially in early disease.
Yeah, I would agree with Dr. Dombrowski. This is Dr. Halskat from Johns Hopkins Maternal-Fetal Medicine and Critical Care, and I totally agree with those statements. And then also, if I make changes to a ventilator, I'll typically do another arterial blood gas half hour to an hour later, depending on the clinical status of the patient, to see if the move I've made has been beneficial or not, and what other things we may need to employ.
Perfect. In a patient presenting with fever and respiratory findings concerning for COVID, while awaiting COVID testing, is there benefit to also starting antimicrobials that might cover community-acquired pneumonia?
There was actually one study that I did not include in this particular packet for COVID in pregnant women. And all of the women in this study were treated with antibiotics for presumed community-acquired pneumonia. All of them did well. They were treated with azithromycin, and all of the babies did well. I don't think we have data for that right now. Like I said, I know there's a trial starting with azithromycin and hydrochloroquine in the non-pregnant patient population, but I don't think it's unreasonable to start someone on azithromycin while you're awaiting their COVID testing.
I totally agree with that statement, that I think you should broadly cover patients. I think that is consistent with the SECM and surviving sepsis statement on management of COVID. I think some of the original data were suggesting that the incidence of co-infection with COVID was very low, on the order of 1 or 2%. I think some of the more recent studies, especially more recent reports, especially out of Washington State, suggest that may be higher, 10 to 25%. So I absolutely recommend coverage with antibiotics at the same time as if you're concerned for COVID.
And just another clarifying point, those who are raising hands, we're unable at this time to see that. If you could put your questions either in the Q&A or in the chat box, we'll try to get through them as quick as possible. I have a kind of combined question from two separate people that is regarding tocolysis. For patients in respiratory failure, if tocolysis is felt to be indicated, is there a particular agent that is better for others, and just a generic thoughts on tocolysis. There's been thoughts for withholding for those with severe disease, but not sure where that's coming from.
Well, for me, the first thing I do before I begin tocolysis is to make sure I'm adequately perfusing my uterus and that I'm adequately oxygenating the patient. Depending on what the respiratory complaint is, I am partial to magnesium. Although magnesium can increase your your capillary permeability, in patients such as asthma, it also can be seen as a treatment. So I think that you will have to look at exactly what the cause of respiratory failure would be, and then choose the appropriate tocolytic. In this particular virus, it has been stated that non-steroidal such as indomethacin may want to be avoided. And of course, in someone with sepsis or hypotension, procardia may also be something that might cause issues. So I think you have to carefully evaluate the patient. But before you start tocolysis, I think the most important thing is to make sure your patient is hemodynamically optimized.
Anyone else? Goffman. Sure, it's Dina Goffman. I would also add to that I think those comments on each of the tocolytics are very appropriate. But I think one of the things that we often talk about is if the patient is critically ill, whether sort of the preterm labor is a manifestation of that. And so I think, we would tend to err on the side of caution with tocolyzing these women, because it may be that moving towards delivery may be necessary, depending on whether we've been able to optimize the remainder of the status.
And I think the one reminder with magnesium therapy is that it's a decent amount of fluid for a patient, that I think some of the evidence is suggesting that keeping the patient pretty even in terms of fluid balance is a reasonable goal in COVID. So.
Great. And then this question, I'm a little unclear exactly what they're meaning, but any information about the application of some of the discussed medications, so HCT, Kaletra, et cetera, in a critically ill pregnant woman. I know, Dr. Graves, you kind of assessed this, but maybe opening it up to any additional information that anyone has. Or is that too difficult?
I will say I did not see any trials in any. If they have been treated, they're not been reported, and I did not, and they are no. And most of course, trials do not initially include pregnant women.
And
go ahead, Dr. Jambras, go ahead.
I think it's hard to comment on that because the results are changing almost daily. I think as it stands today, as of 12 noon, we don't have a great 12 noon my time. We don't have a great sense that any medication provides more than anecdotal improvement in outcomes.
Yeah, I agree. That's what I was. Tori Halscott from Johns Hopkins. Yeah, I think if you have a pregnant patient in extremis, I would, if you're at an institution that is utilizing some of those as part of a trial, I think that's reasonable to talk to them about inclusion at that point. But as far as hard and fast data to guide our utilization in pregnancy or without, we're just not there yet, unfortunately.
Okay, and what is the rationale for SpO2 greater than 95%? There's physiologic explanation, fetal hemoglobin oxygen affinity, and some data that a fetus maintains oxygenation as low as 88%.
If you look at the critical care data in pregnancy, there is some data that suggests, number one, you also have to keep in mind that the fetus, it will offload oxygen, but the mother also has to have oxygen as well. So while you may be able to offload oxygen at 88% to the fetus, you also have to adequately oxygenate the mother. And we've had the conversation about preterm labor and fetal dynamics. So I think it's important to know that this is our current recommendation for pregnant patients, to try to keep them above 95% or greater than equal to 95% if possible. I will say on occasion I've let people drift down to 92% as long as the patient seemed to tolerate it pretty well.
I would agree with that.
I'm going to read this. Oh, sorry, go ahead.
I'm a little more liberal with oxygen targets. You know, I think 92% for someone who's critically ill and pregnant, I'm comfortable with that. Likewise with PCO2 targets, you know, I don't really, I'm fine with a PCO2 higher than 50, for example. For me, it's, I think that, you know, permissive hypercapnia is such a cornerstone of critical care management that if we can easily achieve a lower PCO2 and still, you know, obtain lung protective ventilation, I'm fine with that. But in patients who are in extremis, I have no problem with higher PCO2, and I wouldn't alter ventilation strategy to a regime where I think I may be harming maternal lungs just to try and achieve a PCO2 target for fetal indications. But I have no data to really support that. That's my personal kind of opinion.
This is Tori Halscott. I agree with Dr. Dombrowski as well in all those statements. And I think it's an important topic to bring up because from the critical care world, our colleagues a lot of times, besides permissive hypercapnia, will also use the ARDS-net trials looking at oxygen saturation of 88% or above as acceptable. So that may be a worthwhile conversation we'll have to have for any of our pregnant patients to kind of make sure we get on the same page, because we both may be coming with different numbers as our initial goals of what's acceptable. So I would encourage everybody, if you get to that point, to sit down with your intensivist and figure out what number you're hunting for that patient particularly.
Okay, I'm going to move on to prone positioning. There's a bunch of different questions. I'm going to ask one of them, and some of them have been answered in the chat with the panelists, but I'd like to open it up to discussion, especially for those that are going to be listening tomorrow and other dates. Does the panel have any experience in prone positioning in pregnancy, especially after 24 weeks? One of the recommendations by a recent sepsis campaign guideline in COVID patients is considering prone positioning in refractory hypoxemia. Do you think it's reasonable to deliver the patient after 24 weeks in order to be able to do so for prone positioning? So that has a couple of parts. The first was the prone positioning. I'd like the panelists to discuss, and then maybe talk about delivery in order to do prone positioning second, please.
So I think a couple things. So number one, I think that, prone positioning is a practice that is very simple. It's just putting the patient face down prone to improve VQ matching and improve oxygenation. I think it is very institution specific regarding the amount of experience you have with prone positioning. I trained at a place where it was a routine thing where our nurses would do it without physician involvement if the physicians asked them to, and it was a very safe procedure. Other institutions don't do it very much, and there's been suggestions from kind of critical care experts nationally that maybe now during the COVID time is maybe not the best time to be starting this, because simple things like losing IV access while flipping a patient prone who is on vasopressors can have catastrophic consequences. That being said, if your institution is a place that has experience with prone positioning, I would fully support doing that during pregnancy. I've done it myself in the 3rd trimester. I think you need to adequately pad and make sure that there's not undue pressure on the uterus and great vessels, but it can safely be done. I would not deliver for the purposes of prone positioning, and I would definitely consider prone positioning before something more invasive like ECMO.
Yeah, I agree. And actually, I've kind of taken a donut before and kind of fashioned it to kind of take pressure off the uterus, but I think that I would not deliver someone at 24 weeks in order to facilitate prone positioning. I think you can achieve that if you're experienced at it in your institution by some different means.
Okay, we'll move on to this question is there any precaution in using prostaglandin analogs like carboprost in treating postpartum hemorrhage in those that are COVID positive?
Hi, it's Dina Goffman. So I think I haven't been able to find anything published on this, but I would just share that one of our early index cases was a patient who was intrapartum, the diagnosis of chorea with no other symptoms and had a significant postpartum hemorrhage, was treated with the usual medications, including carboprost, and then needed intubation because of the significance of the hemorrhage, and was then had significant bronchospasm and difficulty ventilating, and that prompted swabbing, which subsequently came back COVID positive. So I think it's important to know that we're seeing a fair number of atypical presentations and sort of what's not been described outside of the obstetric population. And I think here in New York, we're starting to see many more of these unusual presentations in our pregnant women.
Thank you for that. So this is another that may be institution specific, but I think important to discuss. Any general recommendations or thoughts regarding a location of delivery? So for each of your institutions, for your PUI/COVID positive patients, 34 weeks and higher with new respiratory decompensation. They note balancing desire to limit movement back and forth and avoiding unnecessary delivery, but also performing delivery in the setting of optimized for vaginal delivery, C-section, and avoiding an emergent C-section. Does anyone want to take that as to their institution? Sorry.
Sorry, it's Dina again. I would say I think that this is one of those ones that's really tricky because I think it will be institution dependent. I think it will depend on where your ICU is, how far away it is, who can get there, who's staffing it, what your OB anesthesia resources on the floor look like. So I don't know that there's a one-size-fits-all answer for this. I don't know if other people have a different perspective.
Totally agree with that. And I think that also it's good to have plan A, but also plan B and C. We have a very thorough, you could say complicated, but excellent flow sheet here put together by my colleague, Jeannie Kelly, that has kind of a lot of if-then statements in it that allows for patients to deliver either in our COVID ICU or on labor and delivery. So to really try and capture all bases, I think is important as well.
I concur.
I agree.
Okay, I'm going to move back to the chat because I think some of the responses were to the panelists and not the entire crew, but indications for fetal monitoring of patients on a ventilator. We kind of talked about it a little bit, but needed if the patient is not hypoxemic or hypotensive.
Yeah, and I responded to, this is Dr. Halscott, I responded to that in the chat, but just to reiterate that, I think typically in my practice with these patients, and I certainly welcome my colleagues' opinions as well, when they're in the immediate stabilization phase, so they've been intubated, brought to the ICU, those sort of things, typically keep them on continuous monitoring until we feel like they're in a stable situation clinically, and then reevaluating based on what the underlying maternal or fetal conditions are from that standpoint, and then in accordance with the local protocols too. So I don't think there's a fully right or wrong way to do it. I think it's having that conversation, especially once the patient's been stabilized, how you may change your monitoring. But I would advocate that for certainly most patients in the initial stabilization period, continuous monitoring, if feasible, can give you some more information to potentially act upon, as well as on the other side, hopefully some reassurance that you're getting good placental perfusion as well.
I agree.
Okay, and there was
one of the things we have to be willing to do, at least in my practice, is be willing to ignore fetal monitoring in certain circumstances, either by not monitoring at all or by monitoring and just not looking at it. For example, someone who's in respiratory distress and is getting intubated may have a terrible tracing during that time period, but once you stabilize them, it will recover. So I treat it much like a DKA type picture, where I know that it may look bad for a while, but will get better once I fix the underlying problem.
And actually, as I was doing the lecture, sometimes I just decide not to monitor. If I've decided we're not intervening, I decide not to monitor, and then I don't have to. That's just one less thing that's going to make my blood pressure go up. And then once I get the patient stable, then I resume monitoring at that time. Or if you decide you're going to just deliver the patient if she had codes or something of that nature, then I think you really have to have that conversation on the front end.
And just a reminder to listeners, if they want something read out loud to the entire panel, Q&A is probably the quicker way, as the chat has gotten full with kind of back and forth, but I'll try to get to both. There is a question in here that was answered to all panelists and had such a great response. I'd love to bring that open to the entire panel. Is there a different impact of betamethasone versus dexamethasone on pulmonary injury? Not necessarily from a fetal lung maturity point of view.
Yeah, and this is Tori Halstead again. I think I responded to that in the chat as well. And it's not to my knowledge. I'm sure there are smarter people out there than me with much more pharmaco knowledge than I have that may be able to give you some information, but there's nothing that jumps out to me. I think one thing to keep in mind when we're talking about steroids for a lot of these patients, especially patients in the COVID cohorts that haven't survived, the steroids we utilize both in medication, dose, and duration are significantly different than betamethasone and dexamethasone we use for fetal lung maturity. So I'm not sure it's an ideal comparison. And I think it may be one of those questions that takes some time to get some more information on and some more patients, unfortunately, to get some more information on. And we may not get enough information to say that there really is the increased risk that we see in the COVID patients who are probably receiving different, more ICU usual steroids to try and help them when they're in extremis.
Perfect. On the Q&A, there's been a request to share your if and then protocols. If you would send that to any one of the panelists, we can try to have that through SMFM so that we can give this to all of our members or those that are on the webinar. Please. Trying to go down. A lot of the chat has been answered. Does anyone have anything they want to add to the Q&A? There was some talk about rapid sequencing. Do you guys want to bring that back to the actual panel discussion? I know it was answered, but again, that was another one that looks like it went to the all panelists as opposed to the entire audience.
Yeah, that was another one that I jumped on. This is Tori Halstead again, and I believe it was one of our OB anesthesia colleagues who had written in that question about rapid sequence intubation, rapid sequence induction, RSI. And that's the prevailing wisdom currently for patients that are COVID positive or COVID presumed in respiratory failure is to move to quick, early and quick intubation procedure to try and minimize risk to all the providers. And I would agree with that statement as well as for pregnant patients. It can be more challenging. It's a more rapid, as the name entails, procedure, but I wouldn't recommend changing things and doing things differently for our pregnant patients. Another caveat to that is the recommendations from our governing body, Society of Critical Care Medicine, a lot of times is that the most experienced intubation provider should be the one performing the intubation. And my colleagues in ICUs around the country have been doing it in that manner as well. Usually it's the attending who is intubating a patient that is a COVID confirmed or COVID suspected in those sort of conditions. So I would say yes, rapid sequence intubation would be the typical, and I would suggest that be the typical approach and by the most experienced provider available.
Yeah, I think to just to piggyback on that for briefly, I think that there is some suggestion nationally that intubation may be more preferable over non-invasive ventilation techniques as it reduces the spread and aerosolization of virus-containing particles. So maybe a slightly different practice in that regard than we use for our standard ICU patients.
There is a question kind of to all, I guess, if there's any known drug trials that are occurring in pregnant women. Are they ones that people can reach out to certain centers and bring any of their patients into these drug trials, or are they just site-specific drug trials? And does anyone have any information on that just to share with the entire group?
Right now, I
would take the silence as a no.
Yeah, well, right now, the only trial I know, there are a couple of trials, but I think they're site-specific and they're not there. And so I don't know exactly how you would enroll a patient in one of those trials, but I know that they're site-specific and not generalizable to current medical treatment at this time.
Yeah, the one that comes to mind, this is Tori Halstead again, is the Solidarity trial that the WHO is putting together, multi-center, worldwide, multi-arm trial right now. And I was actually just trying to pull up to see if I could quickly see if they had pregnancy as an exclusion criteria. I don't see that, but I haven't had time to go through the entire protocol in the minute or so between that question being asked and that answer. But so Solidarity is the name of the trial, and it's by the World Health Organization. So that may be something to look into for our sick patients.
Also not related to drug treatments, but there is the priority study out of UCSF that you can Google and have your patients be contacted by them. You don't need the IRB. Their website is pretty clear about the different things that you need, but that is for any PUI or COVID positive patients to look at outcomes. So that's another one that I'm aware of, but it doesn't have to do with the treatment, drug treatment, but it's at least for COVID positive patients and looking at outcomes. Okay, we're going to go back to the Q&A. People have added some. Is there comment on the fluid management on COVID pneumonia patients? Is there restricted fluid recommended?
Yeah, so just to answer that, I've posted a link before. I don't know if people have seen it, to the SCCM Surviving Sepsis guidelines. I'll post it again. It's a PDF file that goes into some of the fluid management in terms of which fluid to use and fluid balance. I think in general, the thought is a more even fluid balance is something we should be aiming for.
Yeah, I agree. That's been a topic of ongoing discussion for us in the ICU world is there more of a happy medium and not giving patients as much fluid that we typically would do in sepsis, in ARDS from sepsis. So we're trying to balance that and figure that out.
Great. There's a question on 100% non-rebreather as a safe or safer than nasal cannula. Any thoughts from our panel or concern that increased O2 flow might cause aerosolization?
So this is Tori Halscott. So I think we're not really sure how much aerosolization we have with different modalities that are non-invasive, but I think the concern exists when you start to increase the oxygen flow that's going towards the patient's face. They're breathing out against that flow. It certainly probably increases the dissemination of particles. So I would be cautious to utilize a lot of those, especially the higher flow and high flow nasal cannula, those sort of things that deliver a rapid volume that it may put the providers at risk. I don't think it's going to change the outcome if we have a patient who is having respiratory distress and we need to escalate their supplemental oxygen. They're probably pointed towards intubation, especially if it's COVID related. So moving right towards that rather than trying to stave it off with non-invasive maneuvers would probably be the better idea.
There's a question, I believe, about choreo in labor and if the patient is febrile and laboring, and with respiratory symptoms, whether or not treating for choreo at the same time. This is mostly to Dina, I think, just given the comments that you had earlier on your atypical patient. But if you could just kind of go over how you might treat an atypical patient that may or may not be COVID positive or PUI.
Yeah, so I would strongly suggest, and we're hoping to write this up and get it out there sooner rather than later, but we've seen multiple patients where the only initial symptom was an intrapartum fever. And I think the first one, was the one that we took to the OR, and it only occurred to us once she was intubated and had some difficulties with ventilating, that swabbing her would be a good idea. But since we've shifted towards swabbing more patients, we've definitely seen intrapartum fever as sort of the first presenting clinical sign. So my suspicion is growing that intrapartum choreo should be on people's radar as an opportunity to treat the choreo, but also swab patients. I do think that's important and evolving as we speak.
Okay. There is any information regarding modifying the MGH COVID workup treatment algorithm to pregnant patients, if at all, from this group? Is that something this group is familiar with? Sorry.
I'm not.
Yeah, I am somewhat. I think that this is Tori Halscott again. I think we're all trying to figure out what's the best way to approach these patients, and I don't know that we have that figured out yet. So I think it's a topic for ongoing discussion and ongoing clarification and refinement, both within institutions and between institutions.
I would just add to that, that as we're seeing these patients, there's sort of a strong interest from the infectious disease adult team to sort of know about them and have that collaborative conversation. Obviously, we have our own internal algorithms for treating and, you know, which labs to send and which medications to start and when. And I think we're just in the early stages of learning whether there are things that we should consider doing differently in pregnant women. But I would say at this point, we're sort of using those adult algorithms and having a multidisciplinary discussion in real time.
There is a wonderful kind of back and forth to everyone regarding anemia in the situation of a COVID-19 positive. I'm going to bring that online for discussion, just so that the benefit of people who are going to listen on different times on demand can be a part of the answer here. So the topic is transfusion and the concerns for anemia in a critically ill patient or COVID-19 positive. Can we just bring just a tiny bit of that online so that people can benefit from hearing it aloud?
Sure. I think the question was, is there, what hematocrit do we where do we consider? And so I usually use the guidelines of a hematocrit 23% or less, which is the guidelines, the general guidelines for critically ill patients. That's about a hemoglobin of 7.2. That's kind of where I fall in considering transfusion for these patients.
Yeah, I agree with Dr. Graves, and she is much smarter than I am because I just keep it simple, you know, just 7.0, and I think I put back in the chat, and then 8.0 if they have a recent cardiac event, you know, heart attack associated with that, or they're post-op from some sort of cardiac surgery, something like that. And those are the goals I typically use. We have to be careful with patients with pulmonary dysfunction, especially with ARDS, that we're not giving them too much fluid in general, especially too much blood can cause other, you know, concomitant adverse effects for the lungs. So it would be a balance, but I wouldn't try and transfuse them much higher than that, you know, 7 to low 20s hematocrit range.
And I think just a little more broadly as well that, you know, so far from what we know, that the best treatment for COVID is just kind of, I think, good ICU care in general. So that I think we use all the same transfusion goals and ventilator goals for our COVID patients until we have good evidence otherwise. So I completely agree with all those statements.
Okay, what are the panelists' thoughts on vitamin C infusion in the treatment of sepsis, ARDS, i.e. the citrus ALI trial and ongoing VIC-TAS trial? I know pregnant patients were excluded, but there are many hospitals, to your knowledge, are there any hospitals, to your knowledge, using the vitamin C in the treatment algorithm? And if so, how about for pregnant patients? Is anyone aware?
So I'm not aware, Dr. Halscott from Johns Hopkins, I'm not aware of anyone using it, certainly for pregnant patients, or kind of using it consistently for other patients as well. I think it's an interesting ongoing area of research. I don't know that it's kind of been solidified as of yet to be widespread common practice currently.
Yeah, I think the recent trial in the New England Journal was not straight vitamin C, but put a little bit of a damper on some of the excitement surrounding vitamin C for a lot of people.
Agreed.
So since you all are from hospitals that are seeming to be hit pretty high with the COVID-19, are there any tips or anything that you've seen that you'd want to have spread to this group, anything that you've learned for those of us who are just barely into the COVID-19 patient populations, for those that have had some? Are there any tips that you can say to this group?
I think one of the things that's really helped us is having a few point people really manage our response to it. So you don't have, you know, kind of too many cooks spoiling the kitchen with kind of, I think you have to have a consistent set of guidelines and protocols for evaluation and management of these patients, and not get in a place where different providers have different thresholds for evaluating or managing patients. So I think that consistency is really, really important.
Yeah, I would just echo that. It's Dina Goffman. So we're sort of in the thick of it here and escalated relatively rapidly. And I would say a couple of like operational things is that you need to get a core group of people together quickly, sort of a leadership team. You need to meet multiple times a day. You need to be called when these patients hit the floor so that the teams get it right. It's a lot of new information, and teaching people how to do this universally has been a real challenge. So I would just encourage people to think through that. The other two things, I think, for people who are in places where it's starting to come, if the numbers get to what we're seeing in New York, I think things to think about on the front end are like, what's your algorithm? What rooms are you going to use? How are you going to transport patients? How are you going to handle moms and babies? Are you going to cohort patients? And then the other thing, just to finish, I think I sort of alluded to it in one of my earlier comments, but I think we're in a unique position in obstetrics, which is that if patients are asymptomatic and have COVID-19 or mildly ill with COVID-19, they're in the general population, they're being asked to stay home and they're not being swabbed. But I think that our patients are coming in for usual obstetric indications, to be triaged, to be induced, to have their cesareans. And many of these patients are in fact positive. And I think it's a unique part of the hospital that people don't always think about, where these patients are coming in for care, including their ultrasounds, their prenatal visits. And so I think we've had to move relatively rapidly once that became clear to us, the number of patients that would be in contact with us and our teams that were positive, but not clearly recognized to be positive yet.
So there's a question, are any of the panelists using non-invasive cardiac output monitoring to guide fluid management to prevent fluid overload?
I do a lot of point of care ultrasound to help me decide fluid management. That's in general my preferred strategy.
And that is mine as well. Yeah, typically I don't use a lot of the invasive monitoring. And I'd say a lot of the ICUs in general have gone away from that. We did do a lot of that for some time, but now typically point of care, echocardiogram, and some other measures utilize.
That's great. Okay, as we're wrapping up the last 5 minutes of this panel, and thank you for everybody who has contributed, do you have any other pearls of wisdom for those of us who are listening? I know we kind of just alluded to that beforehand, but just to wrap up, anything that you'd like to share with the group, or even pose your own questions to the entire panel as you're navigating this pandemic?
I think probably one of the most important things is to kind of keep an eye on the guidelines and things of that nature, because they're changing daily. So it's important to just try to keep keep yourself updated as much as possible.
I agree, and this is
yeah. Just a couple more things I see being chatted in right at the end. A lot of questions about PPE and what to use when and telehealth. So I think, yes, lots of telehealth opportunities, and we're ramping up rapidly with that. I think there are published recommendations from various places about what sorts of visits can be streamlined, what can be tele, and what will still need to be in person. And I think the PPE conversation is evolving multiple times a day based on supply and demand and shortages, which I know is a challenging time for all. But I think one of the specific questions is whether pushing is considered an aerosol generating event in a PUI COVID positive patient. The current feeling on that at our organization is that it's not, where we are moving to sort of full PPE in terms of an N95 is for cesarean, given the risk of conversion to general anesthesia, as I shared with our previous case. But I think those are evolving, and as the N95 situation evolves, we will have more and more information, probably with some information from our organizations as well.
Yeah, this is Tori Halscott. I just want to add the other thing. We're probably all getting a little bit of email fatigue. We certainly here, we have a lot of emails every day, and I would say try and make sure you get through all of those, look at all of those, see what new information, what things have changed, because we've all experienced things changing day to day, even hour to hour. So we hear you. We're all going through the same thing, but take the extra 30 seconds or minute to look at each email and see maybe how we're doing things different at each of our institutions. And if anything comes up that's a great idea or it's working well at any places, share them with all of us so we can keep taking great care of these patients too.
And I think one thing that we've done here that really helps is try and have centralized websites with all the updated protocols. So if you miss one email, you can always go to the website and get the most recent protocol, most recent flow sheet, so you don't have to keep searching through email to try and find it that way.
Great idea.
All right. I'm trying to pull any last questions that are here. How about this last question? How are hospitals handling labs? Are you using the tube systems for any COVID positive patient specimens?
I actually don't know how our samples get to the lab.
I was thinking the same.
We're hand delivering ours, and that's been a big point of conversation. I think a couple of reasons. I think that turnaround time for some of these swabs remains challenging, and I think the sooner they get to the lab, the sooner we can try to get them run and get results, which will then continue to impact care for moms and babies. So right now, the plan is hand delivery.
Perfect. Well, out of respect for everyone's time, I want to just thank Dr. Graves for her excellent presentation, and then the entire panel for the excellent Q&A that was to follow. I know that with everyone's time being crunched and everyone having more and more things on their plate, your time is limited, so I do appreciate everybody's time coming on to this webinar. Again, just from the SMFM, this will be it has been recorded and it will be on the website really by tomorrow, but you can start looking for it in the beginning of tomorrow, but it should be there by 5 p.m. Eastern Standard Time tomorrow. Thanks again, everyone. Have a nice day.
Thank you.
Thank you.